to take away, I think volleyball was a sport, and to maintain their Title IX requirements, they wanted to make cheerleading a sport. And this judge kind of looked at what cheerleaders did and felt it wasn't a sport. Well, and I've been doing sports medicine for 20 years. I was a youth coach in Pop Warner football, saw the cheerleaders there. I've been taking care of high schools my entire 20-year career, and also at the college level. And I can guarantee you, cheerleading is a sport. You know, the problem is the judge is probably thinking of, you know, girls standing on the sidelines and waving the pom-poms on Friday night, which the girls actually probably don't care that much about. Their competitive season starts, you know, in November, December, January, and they work as hard as any athlete at any school that I've seen. And we all know about gymnasts, you know, they go year-round, nonstop, you know, work themselves, you know, to a lot of overuse injuries. So, you know, every time I see cheerleaders in the office, you know, I'm very confident that they've worked really hard to get the injury that they have. As far as, you know, injury rates, you know, again, if you look at cheerleading and gymnastics, the injury rates are as high as any of the other sports that girls are participating in commonly, like soccer. You think of soccer and field hockey and softball and all the sports, but, you know, these girls are getting injured at just a higher rate. And if you look at the catastrophic rate of, you know, catastrophic injuries, they're actually very high. So again, proving that, you know, these girls are putting themselves at risk, you know, depending on the position that they are on the cheerleading team or the event that they do in gymnastics. And we have dealt with very, very serious injuries. The first gymnastics meet, when I was an orthopedic resident, we used to cover some Rutgers events. So I had to go, they said, oh, you want to cover gymnastics? I'm like, sure, that'd be great. So I walked into the gym, and a girl from the other team walks in with a halo on her head. She had broken her neck in about, you know, an event like about a month prior. They fused her neck, put her in a halo, but felt it was good for her psychologically to get back into the arena where her thing happened. So here I am covering my first event as a resident, thinking, oh my God, what if somebody breaks their neck? What the hell am I going to do here? So, you know, these injuries are real, and, you know, I take this very, very seriously. So even when I stand on the sidelines of a high school football game, you know, and the girls are doing flips and all the things that they do and throwing each other, I'm paying as much attention to them as I am on the side of the field, because something just as bad, if not worse, can happen to them as the football players that everyone's worried about. You know, as far as the mechanisms of injury, they occur in all different types. You know, they have the girls and cheerleaders on the base with the spotting, you know, holding people up. They're requiring a lot of upper body strength. The cheerleaders and the gymnasts are tumbling. Then you have the falls from height. So you have the girls who are propelling themselves on uneven bars. We have the flyers and cheerleaders. I mean, you know, these are where we see some of the major catastrophic injuries. And then you can see, as far as the injuries are concerned, I mean, luckily, the majority of what we see are sprains and strains and things that are relatively, you know, straightforward to take care of. But, you know, we do deal with, you know, bad injuries, ligament injuries, you know, there's the concussions that occur. So they run the entire gamut of athletic injuries that every other athlete sees. So I'm going to kind of start off with, you know, working my way from the top down and shoulder injuries, because I think in this particular population, I see a lot more upper extremity problems than I do lower extremity problems, to tell you the truth. So traumatically, in the shoulder, we see either glenohumeral dislocations or subluxations. Again, if you think of the positions that they're putting their shoulders in, there's a lot of abduction, external rotation, where they can just, you know, they tend to be a generalized ligamentous lax group of athletes anyway, so they're a little bit more susceptible to subluxations and dislocations, so it's not uncommon to see a dislocation. If they've had them once or twice, you can usually get, you know, I think as athletic trainers, you all know how to pop a shoulder back into place, so I don't have to go over that, but that's one of the things that we'll see. AC joint sprains, again, that usually occurs as a result of a fall on the lateral aspect of the shoulder. Most of the AC sprains in this group tend to be relatively mild, grade 1 or grade 2, occasionally in grade 3. Now, a type 5 AC sprain, where the distal clavicle pops through the deltotrapezial fascia and then can't be reduced, that's something that requires surgical treatment. But I can honestly say I've only seen that, you know, once in my entire career, where I, you know, do a surgical repair for an AC sprain. So most of them just require a period of rest with a sling, get their shoulder motion back and their strength back, and they're usually back anywhere from 3 to 6 weeks. And then instability is the other thing that I think I see the most of. You because it presents in many different ways. So the athletes can come in and say, I feel like my shoulder's popping out of place, and that's very obvious if they're saying that, but a lot of times they just come in with vague shoulder pain. So we're dealing with adolescent, high school, or college athletes who come in with this vague shoulder pain, and they'll say, well, I'm worried that I tore my rotator cuff, I have rotator cuff tendonitis. Well, primary rotator cuff disease doesn't occur in young people. It occurs in old guys like me, but the young people, if they're having rotator cuff symptoms, it's secondary rotator cuff tendonitis. And the reason it's secondary is because they have underlying instability of their shoulder. So as the humeral head is sliding off the glenoid, it's usually multi-directional type instability. The rotator cuff starts to fatigue, and now they have the weakness. So they'll say, they'll say, after I've been swinging on the bars or after doing certain routines, my arm starts to go dead, right? They lose the strength in their arm. They start to get tingling into their fingers. They get the classic dead arm syndrome, and that's a sign of instability. Okay, so the treatment for almost everything that we see in this, in this top group is going to be, number one, we've got to give them a period of rest to let the shoulder settle down. If they're starting to lose their strength where they can't protect themselves in certain positions, that's when they're at greater risk for a dislocation or a subluxation. So get their shoulder to rest, and then we have to tell them, it's time to, you understand now you have some looseness that's built into your shoulder. The looseness is what has made you a good athlete in this particular sport, but you've now crossed over to the other side where it's pathologic. And we've got to fix that with, kind of a steady course of rehabilitative exercises, rotator cuff strengthening, and scapular stabilizing exercises. So that's kind of, a hallmark of managing that. Now, when I work these girls up, there's, if they come in and they've done, I'll get some x-rays sometimes, but it's more for the parents than anything else because they very rarely do they sustain a fracture or anything like that. So if I'm going to do but if they're not responding to conservative treatment, then the treatment of choice is going to be an MRI arthrogram. And the reason I go with an MRI arthrogram is because I'm looking for labral pathology. But what you usually end up seeing in these cases is rather than seeing labral pathology, because again, they don't pull the labrum off of the glenoid, it's just they have a patulous capsule. And so that, the patulous capsule allows their humeral head to slide off of the glenoid, and you're not going to see labral pathology. So again, we kind of do these MRI arthrograms as an exercise to make sure that there's not labral pathology, but it's just something that we need to do. And so I went over the hallmark is going to be conservative treatment. Now, the other thing that I've seen some athletes be somewhat successful with, I don't quite understand all the physiology of physiotaping, but there is some reports that the physiotaping is helping the girls feel more stable with their shoulder problems. Now, every now and then we do have girls who come in and they just don't get better with conservative treatment. Either they have recurrent dislocations, recurrent subluxations, or their instability is an issue that just can't be resolved and they can't back to the level of where they want to be. So there's really two ways to address shoulder instability. So one would be through open surgery, and another is through arthroscopic surgery. Now, if you think about it, again, going back to what I said, it's rare that they have labral pathology. If a girl comes in and she's dislocated her shoulder and she has a Bankart lesion where the labrum separates from the glenoid at the anterior inferior corner, that's something that's easy. That's a home run. You can just go in and arthroscopically put the labrum back, and they do relatively well. But unfortunately, this is more of what we see in this arthroscopic photo. The labrum is completely intact, and if we go back to that MRI arthrogram picture, they really just have this capsular laxity. So when I explained it to the families what's going on, I said, think of your glenohumeral joint being held together by a balloon, and that balloon has now expanded to the point where it allows the shoulder to slide in and out. And we have to try to decrease the volume of the balloon enough that it will hold the shoulder in place, but not decrease it so much that it's going to make the shoulder too tight and not be able to perform your desired activities. For the gymnasts and for the cheerleaders, for girls who have hyperlaxity, even though it's a little old-fashioned, I still like to go with the open surgical procedure. And the reason being, this is a classic capsular shift. So essentially what I would do in this operation, I was incise the capsule first horizontally, and then tee it vertically on the lateral side. And so you take these two flaps of tissue and kind of fold them over themselves. So number one, you thicken the anterior capsule, but more importantly, you decrease the volume. And I can reliably decrease the volume of the shoulder through open surgery. And what we really try to do is, if you understand the anatomy of the shoulder, there's what's called the inferior axillary pouch. It's down here on this part of the shoulder. And what we try to do is take away that inferior axillary pouch. Now, you worry about maybe can you over-tighten these girls' shoulders. The truth of the matter is, again, they're dealing with kind of generalized ligamentous laxity anyway. And what I tell them is that even if you're tight, you're probably going to stretch it out over time. So a year or two from now, that if they're a little tight, by the time they get back on the uneven bars or back doing their stunts, their shoulder's going to loosen up pretty nicely. So open shoulder surgery tends to work pretty good. But you can do cases of arthroscopic capsular plication, and this is an example of one arthroscopic stitch. But what we basically do is take little pinches of the capsule. This is the bottom of the glenoid, this is the front, this is the back of the shoulder, and you would end up putting about 6 or 7 stitches, like a stitch here, stitch here, stitch here, and just kind of pinching that capsule together and decreasing the volume. The problem is you don't really get, this particular technique doesn't account for the global laxity because it's not just in the front of the shoulder, it's all the way around, and it's your ability to really fine-tune your volume reduction of the shoulder is not as good. But there's certain patients that are good candidates for that. Again, if you see someone who has on MRI Arthrogram has some obvious labral pathology, you can combine a labral repair with a capsular plication to handle that. So, it gets a little technical, but both of these operations, I think we have to forewarn the girls that even though we tighten up their shoulder, they're prone to having it stretch out over time. So after they recover from the surgery, it's critical that they continue on with rehab. You just say, look, if this is your problem, doing rotator cuff exercises and scap stabilizer exercises have to be part of your entire career. When you're done being a cheerleader, done being a gymnast, then you can stop if you want to. But until then, you really should be doing it year round. And I find that it kind of sets in after a while, since I do harp on it quite a bit. All right, so next is wrist pain. And again, as I said, a lot of what I see in this population is upper extremity injuries. And we see a lot of overuse injuries in the wrist. And I think they fall into a couple of categories. There's obviously stress injuries to the bone. We see some dorsal impingement. Now, I think that's a really common thing that I see in this group. I'm going to go over that, and then TFCC tears, which is a little less common, but something that everybody always thinks about. So with the dorsal impingement injuries, I think almost, if you think about what the girls do, they put their wrist into hyperdorsiflexion, and the back of the carpus is kind of banging into the distal radius. And they just have this persistent pain. Sometimes they'll develop a ganglion cyst in the area, a palpable cyst that is painful, but mostly you really can't find anything. And it's the easiest way to treat it is with some form of a dorsal block splint. So you can prevent them from hyperdorsiflexing when they go in. Every now and then they'll start to get some hypertrophic bone. They'll get a ridge on the distal radius, just at the level of the joint surface, or they'll get some bossing on the metacarpal net, on the base of the metacarpals or even on the carpal bones. And rarely the hand surgeon will have to kind of debride that and take that back surgically. But usually if you can treat it with proper bracing, occasionally in really bad cases where they can't compete, give them a steroid injection or something, that'll cover that. So here's, as far as overuse injuries are concerned, I think the two that I see that I worry about the most are, number one is distal radius growth plate injuries, because again, we're dealing with a lot of girls who are skeletally immature, and they end up getting a stress injury right where their distal radial growth plate is. It would be right around here. So you see them in the office, and they have some widening of the growth plate. Actually, I have a slide of that in just a second. But this is the one that I worry about a little bit more, because it's a scaphoid stress fracture. So everyone thinks of scaphoid injuries as the fall onto the hand, like the skier injury, or any sport where you fall onto your outstretched hand and you get that snuff box pain. But if you have a girl who comes in and she says, my wrist really hurts, and they don't remember a particular traumatic event, but it's just getting worse and worse with time. I've seen a few cases of this over the years where I examine them, they act just like a scaphoid injury. So they have pain to palpation of the snuff box. If you do resisted pronation and supination of the wrist, they complain of pain over their scaphoid, or they hurt on the dorsal pole of the scaphoid. If you take an x-ray, the majority of times it's going to be negative because they don't develop a fracture line. But if the symptoms persist and they're not responding to wrist and things, to rest and wrist splinting and things like that, then you get an MRI, and this is a case of a proximal pole scaphoid stress fracture. Now, if they were to continue to compete with that and miss that diagnosis, that could go on to complete fracture. In this particular case, where it's a proximal pole fractures, once they complete, have a very high risk of non-union. So you need to be a little bit aggressive with them. You either say, look, we're going to cast you, and you're probably going to cast them for somewhere to 6 to at least 8 weeks until it completely heals, because you want it immobilized. But in the more aggressive cases, you can do percutaneous screw fixation of the scaphoid to get that to heal. Because if this goes on to a non-union, then it requires open surgery, potential bone grafting. So again, it's something to just keep in the back of your mind, because it's more common than you might think, and I've seen a few of them over my career, and certainly my partners who are hand surgeons have taken care of more of them than I have. And here's an example. This is a young skeletally immature athlete, and this is that distal radial stress injury that we talked about. So just like when we see little league or shoulder, what do we look for? Widening of the proximal humeral growth plates. See the same thing in the distal radius. She's starting to get osteolysis of the distal radius. See the bone getting eaten away there from repetitive landing on the wrist. So the overuse injuries in this population are really a big part of things we take care of. And I'll go into overuse injuries a little bit more towards the end of the talk, but you always have to think about those types of things. TFCC tears. Now I think this is an overdiagnosed problem. I see a lot of, because there's a lot of vague wrist pain, and usually the people say ulnar-sided wrist pain. They hurt right over the distal ulna or in between the distal radial, on the dorsal aspect of the distal radial ulnar joint. You can't really explain the pain, and everybody likes to think of TFCC tears. The TFCC is almost like a meniscus of the wrist. It connects from the ulnar styloid and goes onto the top of the distal radius, and it creates like a trampoline of a fibrocartilaginous tissue in this area. And certainly from axial loading and rotation of the wrist on the TFCC, you can get tears. So a true TFCC tear tends to have pain, like I said, on the dorsum of the distal radial ulnar joint, but the athletes will report like a catching or a locking or a clicking in that part of the wrist. It's relatively painful. In other words, they have mechanical type symptoms. So usually this is going to be relieved with rest. A lot of tears are just relatively minor frame type tears of the TFCC. You can cast them, you can brace them, you can splint them for a while, give them some rest. And again, it tends to be an injury that occurs with hyperdorsiflexion of the wrist, so if you can give them that dorsal block splint, that might take care of it. Now this is an MRI arthrogram. If you think you're convinced that you have a TFCC tear and the patient isn't responding to conservative measures, the way you're going to diagnose it is with an MRI arthrogram. You can see some of the dye is actually leaking. This is a central tear of the TFCC. It's right in through here, and the treatment is usually arthroscopic. It can either be done with a debridement of the tear, just like we take out a torn meniscus. We can take out a flap of the TFCC, or sometimes the entire complex is usually avulsed off of the ulnar styloid, and that can be repaired arthroscopically with stitches. I'm going to flip to two sides because I don't want to ignore this side of the room. One of the things that we look at when we look at these injuries, you see a lot more when there's ulnar plus variant. So if you look at the wrist, the distal ulna and the distal radius should be at the same level. So that we call that ulnar neutral, but there's an ulnar positive variance where the ulna is longer than the distal radius, and that's not uncommon. Again, it's not uncommon in this population because they're actually loading their distal radius, and they probably stunt the growth of the distal radius a lot. So you see a lot of ulnar positive variance in the distal radius. And then there's also ulnar minus variance where the ulna is shorter than the radius, and you don't really see that commonly here. The reason I point that out is, number one, the ulnar positive variance is a risk factor for TFCC tears, but the other thing that it's a risk factor for is ulnar impaction syndrome. So again, now you're looking at the ulna being longer than distal radius, and instead of having the radial-sided pain, they have the ulnar-sided pain. And today, I just saw a girl who was a cheerleader for one of the local high schools. I worked her up. She had her growth plates were still open, she had a stress fracture of her distal ulnar growth plate, because again, she's ulnar positive variants, so she had to be casted and immobilized for a period of time to allow that to rest. But there are some cases where, especially when the girls are now skeletally mature, they no longer, there's no way to settle those things down quickly. They can't maintain their level of sport. The hand surgeons will do what's called the ulnar shortening. They'll actually resect part of the ulna and shorten it, so that now they level out the joint surface, which takes a lot of pressure off of the TFCC and also prevents the ulna from impacting onto the hamate or the lumina and triquetrum. So a little complex anatomy in the wrist, but again, a very common cause of problems in these athletes. Okay, then there's hip pain. So there's two things that when I see the hip, I do hip arthroscopy, which is something that's becoming more in vogue as the years go by, and it seems like there's an epidemic of hip labral tears in all sports, especially baseball. But we certainly see our fair share of hip pain in athletes, like in cheerleaders and gymnasts, partly because of the high range of motion that they put their hip through. When you have your hip going to high degrees of hip flexion repetitively, that's going to put you at risk for labral tears. But again, no matter what part of the body I'm looking at in this population, I'm always thinking of overuse injuries as well. So as far as, what happened to my slide? There we go. Sorry about that. My slides got out of order. So as far as labral tears are concerned, the labrum is a thin rim of fibrous tissue that goes around the acetabulum. And usually, we used to think that labral tears it's an evolving science. I've been doing hip arthroscopy now for probably about almost 10 years. And when it first started out, all we did was arthroscopically go and shave away labral tears. It was assumed you just caught your labrum and it tore. But what it's really turning out is that the majority of labral tears are secondary to abnormal morphology of the hip. So this is an example of why labral tears occur, because of cam lesions on the femoral head. So the way I explain it to patients is that, at what's called the femoral head-neck junction, where the roundness of the ball turns into the neck of the femur, there's a little knuckle of bone. And it tends to be it's usually on both sides, but as the hip comes up into high degrees of flexion, that knuckle of bone squeezes underneath the labrum and either tears it or separates it away from the edge of the acetabulum. So the girls come in and they complain again of mechanical symptoms in the hip. They feel like they have a catching. They never point to one spot. And the classic finding that they report is the C sign. We say, where does it hurt? And they go like this. They don't even point like this. They kind of grab like this. And when I examine them classically, their pain, I can recreate their symptoms very easily by just hyperflexing their hip and adducting the hip. And as soon as I bring them into adduction, they just like wince or tighten up, or they know that that's the pain that they're getting. And if you ask them, they'll say things like, well, I have a hard time getting my leg in and out of the car, or something like that. But again, in their sport, where they're bringing their hip and their knee way out, they're going to get those mechanical symptoms. So typically, I'll get an MRI Arthrogram to make this diagnosis. Routine MRIs don't help. And one of the, I don't know how many people order MRIs for labral tears, or your doctors order them, but every time I order an MRI Arthrogram, I have them put cortisone in the hip joint. It's really for two reasons. Number one, they may have a mild labral tear that may just kind of go away with little anti-inflammatory effects. If they're getting an MRI Arthrogram, the radiologists are already putting a needle in the hip. So if the needle's in there, put one dose of cortisone isn't going to hurt anybody. And the other thing is, it's also somewhat diagnostic, because if you look at labral tears in hockey players, which is very common, they did a study where they did MRI Arthrograms in asymptomatic hockey players, and 35% of them had labral tears that were asymptomatic. So not every tear is the cause of pain, but if I give them the cortisone injection, and even if they get a week or two of symptom relief, I can be relatively sure that that's the cause of their pain, so that if we're moving towards surgical intervention, I'm more convinced that they're going to get better. And then the options for surgery, generally, especially in this younger population, just like we try to preserve the meniscus in the knee, we try to preserve the labrum in the hip. So we're going to end up doing a labral repair, which again, 10 years ago, even in these young girls, they were just shaving the entire labrum out, just taking the whole thing out, figure it's caught. You don't really need your hip labrum, but it's turning out that it's probably somewhat important. So we can arthroscopically repair the labrum to the edge of the acetabulum, but just as important as we do what's called a femoroplasty, we burr down that knuckle of bone, so now when the hip comes into high degrees of flexion, that knuckle of bone isn't trying to peel the labrum off of the acetabular rim. Then there's femoral neck stress fracture. So again, because you have groin pain and an athlete who's at a high demand, thin person who's at risk for stress fractures, you always have to think about femoral neck stress fractures because they can go on to complete fractures, and that can be a total disaster for the hip. So the hallmark findings for me are pain with forced internal rotation, and I look for a dysfunctional one-legged hop. If I have any clinical suspicion that a girl has a femoral neck stress fracture, she's going to get an MRI guaranteed. I don't take any chances with that. I'd rather have a lot of negative MRIs than miss one femoral neck stress fracture because they can be very dangerous. I don't want to spend a ton of time on ACL tears because you guys hear a ton of talks on ACL, but I will say that one thing, in this population, these tend to be relatively small, petite girls. Every surgeon has their graft of choice. But I can tell you that if you look at we have all kinds of demographic data that shows that the smaller a girl is, the smaller her hamstrings will be. So doing hamstring reconstructions in gymnasts and cheerleaders is probably not a great choice because as a general rule, their hamstring, the caliber of them, tends to be so small, smaller than 7 millimeters, that they have a higher risk of failure. And when I went through the whole transition from patellar tendon to hamstrings and then doing a little of both, I realized that almost every time I did hamstrings, and like a gymnast who's 5'1", 5 foot or under, around that range, their hamstring tendons came out like 6. I put a few of them in and they all failed. So I can tell you, I never do hamstrings in a gymnast anymore. I'll almost always try to do a patellar tendon. If for cosmetic reasons or for whatever reasons they say, well, I really don't want to go with my patellar tendon, because they all do a lot of research. Another option that's starting to come into vogue, and we don't really know the long-term outcomes, is an allograft autograft hybrid. So we can take their hamstring tendon, usually just take the semitendinosus because the gracilis tendon is too small, and mix it with an allograft, and then get a graft that's 8 millimeters or greater in diameter. So it's another option for the girls who want to stay away from their patellofemoral joint. Maybe they have pre-existing patellofemoral pain, they've had really bad patellotendinitis, whatever. There's reasons not to do it, but I can tell you, I would say for 99% of the gymnasts that I do a reconstruction in, I'm going to do a patellar tendon. And my first time I did an auto-allo, it was like one of my best friend's daughter. She was a gymnast, but she was like 5'5", so I said, oh, her hamstring's going to be big. And her mom was real nervous about her patellofemoral joint because she had trouble with it. I took her hamstring out, and it was like the smallest hamstring. I was like, you gotta be kidding me. So I had to like go outside, break scrub, talk to her parents. This is too small. I need to put an allograft in conjunction. It's like, it can only happen when you operate on your best friend's daughter. So good luck. But anyway, so I think the other thing about ACL tears, in my career, especially more so in girls and boys, I have had many times when they recover from the ACL reconstruction. I tell them they go back to 6 months, and I can literally name 5 people. In their first week of practice, they tore the contralateral ACL. It's like the most devastating injury you'd see because they're all back, they're all gung-ho. First week, bang, they come in, they know exactly what happened. So I do think the ACL prevention programs are really key. As they're recovering from their ACL, getting ready to go back, you have to tell them. And I tell them at the time of surgery, you're at greater risk to tear your other ACL than the one that I reconstruct. So if I keep driving that point home throughout the 6 months, those last few months of rehab should be focused on ACL prevention with the contralateral knee as much as you're focusing on getting their operative knee back and ready to play. Because it's just crushing to see that happen to a girl. And then the last thing I just want to finish up with is lower extremity stress fractures. I think again we're dealing with a population. They're usually they're trying to maintain weights. They stay small. They're not. There's obviously the female athlete triad syndrome. So I think you have to have a high index of suspicion for lower extremity stress injuries. Obviously tibial stress fractures are the most common, but there's a lot of other stress injuries that we worry about. I think we're all aware of enough now that X-rays don't usually pick them up. But we can pick them up on MRI. Here's an example of, this is a fibula stress fracture. People say, well, the fibula only bears 20% of the weight of the lower extremity. But fibula stress fractures, I've seen tons of them in my career. They're very common. So you have lateral ankle pain in somebody who hasn't sustained any trauma. Get an X-ray, it's negative. What is it? It's almost always a fibula stress fracture. and I see them, more than enough. And it's just something, I remember like, working down at Ryder, and one of the grad assistant trainers was there, and I said, oh, this is a fibula stress fracture. I never heard of that before. I was shocked because I see it like all the time. It's a very common injury. The way I treat them, again, since luckily we're catching most athletes before they have X-ray positive stress fractures, is I'm going to treat them with activity modification. Stress fracture doesn't mean you're out of competition. Stress fracture means that your bone is, you're seeing too much stress, and we need to cut back on the stress of the bone to the point where you're getting better. It doesn't mean you have to stop altogether. So and I think it's important that the kids know that, because I think when they find out, if they know they can continue to play, they're going to tell you their symptoms. Just like the concussion story. If they think stress injury means you're out for 4 to 6 weeks, they don't want to tell you about it, and they don't tell you until it's too late. If you catch it early, you can keep them playing. If you catch it late, then they're probably going to have to be taken out. And then there's always when they have stress fractures, we need to worry about their dietary concerns. Everyone always talks about calcium, but what's actually more important in the youth population is vitamin D. Right? Most of the kids aren't getting enough vitamin D. They stop drinking milk. They're lathering on suntan lotion, so they don't get any vitamin D through the sun. And if we tested most of our youth athletes, and there's a really great, huge study coming out of Boston that shows that vitamin D levels in injured athletes are really, lower than they should be. So it's something I counsel all my athletes who have stress injuries on vitamin D supplementation. And then I went over the high-risk stress injuries, femoral neck. Medial malleolus is another not so common one, but again, something to think about in an athlete that's repetitively landing on their legs. Pain over the medial malleolus. If that stress fracture goes on to a complete fracture, has a very high rate of non-union. And the other one that's a real disaster is the navicular of the foot. It's that little kind of horseshoe-shaped bone. Again, I have a high index of suspicion on that particular bone, because if I pick it up on an MRI or a bone scan before I see a fracture line, I can take them out of activities and get that to heal. If they get a complete fracture of the navicular, that's most likely going on to surgery, and it really can be a career-ending injury. It's a very difficult injury to recover from. I send a lot of these girls for MRIs of their feet, and when you don't see one particular stress injury, you see these patchy edema in the talus and the calcaneus and the navicular. They are really, beating their bodies up. And when you see these things, activity modification, and say we need to get your bone health back to normal so you can compete at this level is critical. So I always like to end with stress fractures, because I think in this particular population, that's the thing that we have to have the highest index of suspicion for. We all know how to pick up the big traumatic injuries, but these girls are working really hard. Sometimes they're on 2 or 3 teams at the same time. They're not eating, they're not sleeping, and this is what they're at the greatest risk for. So that covers, the things that I've seen the most when I take care of this population.